Tarina and myself are here from the Connect team, which is a program at UNMH, or the hospital at UNM. And our program is called Connect, and it's an early intervention for psychosis program. And I'm Jesse Gonzalez. I'm a social worker. I saw there were a lot of social workers in attendance today. And I'm a therapist and the clinical coordinator for the team, so I kind of handle referrals and things like that. And Tarina is our occupational therapist on the team. Well, let me back it up. So we're going to talk today about just what psychosis looks like and what early intervention for psychosis looks like. So the first thing, and since a lot of you are professionals, you may be familiar with some of this, but the first kind of thing we want to look at is what is psychosis? And psychosis is a really broad term kind of describing a symptom in which somebody has essentially a change in their experience of reality. And that can show up in a lot of different ways. And those are usually significant changes in their perceptions, beliefs, thoughts, and behaviors. The estimated global incidence of something on the psychosis spectrum, which is something I'll talk about a little bit more, is about 2 to 3%. And some of you may be more familiar with like 1% of the population developing schizophrenia. And this statistic is higher because it's not just a diagnosis of schizophrenia, it's any sort of psychosis spectrum disorder, such as the syndromes that I'll talk about in a little bit. And again, psychosis is a spectrum or a continuum. The onset is usually in late adolescence or early adulthood. And there's kind of 3 broad categories as far as the symptoms that are usually kind of put under, and those are positive, negative, and cognitive symptoms. And I'm actually, that's the 5th slide. So I'll let Trina talk from here.
Okay, so I'm going to talk a little bit about the cause of psychosis. And like most things, it is a mix of nature versus nurture, or biological and environmental factors. So the biological factors that are implicated in developing psychosis are genetic vulnerability. So twin studies show that if one identical twin develops psychosis, the other identical twin is at a much greater risk or chance of developing psychosis. There also is evidence that it is caused by a chemical imbalance in the brain, specifically with dopamine. And the developmental process, including hormonal changes that happen, as well as presynaptic pruning, so the brain going through maturation during adolescence, as well as birth trauma. And enlarged ventricles have been implicated in people with psychosis, so there's some evidence that that might be one of the causes, as well as substance use by the person themselves or by their parents. The environmental factors that are implicated in causes of psychosis are trauma, so experiencing traumatic events, stress. We get a lot of young people who are experiencing stress due to life changes, whether that's going to starting middle school, starting high school, starting college, starting a career. And that stress could be positive or negative. So starting college is a positive thing in a person's life, but that amount of stress can put someone at risk for developing psychosis. Social factors include isolation, relationship difficulties, and there are also some cultural factors relevant to psychosis. Specifically, each culture views psychosis differently. So some cultures consider hearing voices problematic or troubling, and other cultures don't see it as troubling. And as Jesse mentioned, there's a spectrum of psychosis. So There can be some behaviors and thoughts that are considered typical, and then too far over on the spectrum could be considered psychotic. So for example, for grandiosity, a young person can be really good at basketball, enjoys basketball, and expects to attend college on a full scholarship. That's we wouldn't consider that a very grandiose thought process. But if the youth is certain that they're so good at basketball that they can just go to Chicago and join the Bulls, that's probably concern for being a little bit too far over on the spectrum and be considered psychosis. Same thing with suspiciousness. It's often young people might feel like at the mall someone's looking at them, but that's not too concerning. But if that person thinks that there is a specific person at the mall who is trying to harm them, that is impacting behavior, and that is something that we would consider a symptom of psychosis. And then hallucinations, specifically auditory hallucinations, it's a common experience to hear indistinct buzzing or whispering. So that wouldn't be a concern of psychosis. But if someone starts to hear a clear voice outside their head saying things like you're a loser or you're a failure, that is when we would start to consider that a symptom of psychosis. So now I'm going to talk about the 3 different categories of symptoms: positive, negative, and cognitive. So positive symptoms are not called positive because they are a good thing for people usually. They're called positive because something is being added to the normal way of functioning. So delusions are fixed false beliefs. Being highly suspicious of others is a symptom. Hallucinations, so hearing, seeing, feeling, smelling, tasting something that other people are not. And disorganization, so confused behavior, confused emotions, disorganized speech and thoughts is another positive symptom of psychosis.
Yeah. And when it comes to hallucinations, I think it's important to point out that people tend to think of just hearing or seeing something, but that a hallucination can really kind of happen on any of the senses. And disorganization, just as a more specific example of that, because that can seem a little bit vague, is like somebody I've seen before sort of just like standing up and practicing karate without in the middle of the room without context or without sort of reason for that. So it can be like a disorganized sort of behavior.
Thanks, Jesse. And now negative symptoms are called negative symptoms because something is being taken away from the person, and taking away from their normal baseline of functioning. So there are 4 A's: affective blunting. So that is a reduction in the range and intensity of emotional expression. So the person is kind of just blunted overall, doesn't express in the same way that they were before. Alogia is poverty of speech. So talking a lot less, or while talking a lot slower. Avolition is difficulty in initiating or persisting in goal-directed behavior. And this one is tricky because it's often mistaken for just people being disinterested or lazy, but it actually is a negative symptom of psychosis. And then asociality is always hard for me to say, and that is isolating themselves, spending a lot less time with people, or only spending time with like their close immediate family who they live with. Negative symptoms are usually the earliest warning signs of a young person or a person developing psychosis. And as I mentioned, they're difficult to identify because they can look like someone is lazy or they just don't care. But they do lead to very concerning things such as deterioration in functioning. So self-care is one that that sometimes people experience a deterioration in. So they aren't brushing their teeth regularly, they aren't showering regularly, social isolation, as I mentioned, and then changes in behavior, like Jesse mentioned, kind of doing things that don't fit the context that they used to not do, having decreased emotions or confusing thoughts. So some delusions or some suspicions, being suspicious of others, and then cognitive changes, which I will talk about next. So the cognitive symptoms that are associated with psychosis are disruption to attention and memory overall. And so that can look like a variety of things. So slow processing, when talking to a person, it seems like they are taking a lot longer to comprehend instructions, poor concentration, poor memory, disorganized thinking, difficulty expressing thoughts. So those two can be identified when a person is talking and their thought process doesn't seem to be following a typical route. Like they get distracted and they start like going off on tangents a lot more frequently. And then difficulty integrating thoughts, feelings, and behavior is a big cognitive symptom. Do you have anything to add, Jesse, to that?
No, I mean, it makes a lot of sense there that when these types of symptoms are showing up, that's probably going to translate to a change in functioning, especially at school. It can be really hard to like understand what's being taught or what somebody is trying to express to them, and then difficulty expressing what they're thinking, which sort of makes sense as far as causing difficulties as far as academic performance or job performance.
Yeah.
Yeah, when it comes to psychosis, early intervention is the critical period is something really important, and that's kind of where our program is around. We have another program that we're closely related to called the Early Program, which is a first episode of psychosis program. And those first episode programs are a bit more common kind of around the country. So some of you may be familiar with those types of programs and what they look like and how they kind of work. So that's been kind of what's been going on as far as research and treatment goes is when somebody has their first episode of psychosis, some people refer to that as a first break. That is when an important time to intervene, because the more episodes of psychosis that a person experiences, the worse their long-term outcomes are. And so a program like ours, what Connect is trying to do is to turn that clock even further back or even backwards. So intervening before they have that first episode and identifying people that are at clinical high risk of developing psychosis, and intervening then and treating people early. And that's really helpful. Like I said, it tends to just sort of improve people's general long-term outcomes, which looks like increased, better functioning at school or work, improved quality of life, and tends to reduce costs in hospital settings and things like that by reducing hospitalizations and lengths of stays and things like that. And so some of these things we've talked a little bit about as far as the trajectory. We see a lot of these kinds of things: social withdrawal, cognitive changes, some of these prodromal symptoms, which are things lower on that psychosis spectrum of symptoms, cognitive changes, and psychosis symptoms are very, very often co-occurring with other things, especially anxiety and depression. And we see that with almost everyone we work with. Essentially, everyone we work with is dealing with some form of anxiety and depression in one form or another, along with some of these experiences of like seeing things or hearing things or having strange thoughts. And with our program at the sort of the top, that peak right there, we're trying to intervene before it tips over into that first episode into sort of full-blown diagnostic psychosis. And the way that we do that is through a couple of assessment tools. One thing that we use is called the PQB, Prodromal Questionnaire Brief, which is a screening scale. So if we receive a referral, we'll usually kind of go through that questionnaire with them first. It's not super refined. I think it's a pretty broad tool. So then what we try to do is assess a little bit further with something called the SIPS, which is a structured interview. Usually takes 60 to 90 minutes, and it's specific questions that we ask everyone, and exploring those types of symptoms that they're having, and can help us to assess if they have a psychosis risk syndrome. And that's sort of like what determines if someone's eligible for our program. So that's kind of how we assess and screen for people being appropriate to our program, since our program is pretty targeted, pretty specific. And when it comes to that SIPS, we're assessing for these three types of syndromes that someone may have. The most common one we see is an attenuated psychosis syndrome, and that's where someone is experiencing subthreshold positive symptoms. So that's like hallucinations, delusions, or paranoia that are on that psychosis spectrum, but not tipping into full-blown psychosis. And so they wouldn't meet criteria for something like schizophrenia or schizophreniform. Another thing that we see less commonly is a brief episode, and that's where someone actually is fully psychotic for a very, very short period of time, like 20 minutes, 25 minutes, and that psychosis completely remits after that episode. And then the third one is a genetic risk, and that's when someone has a first-degree relative that has a psychotic disorder like schizophrenia or bipolar, and also significant deterioration in functioning, which is specifically defined as like a 30% change in GAF, but that's kind of on us and our role to look at that a little bit closer. So we also like to look at differential diagnosis, and some of the ways that we approach that as far as referrals go. We've used some of the kind of ways that we're thinking from the SIPS interview itself as far as looking at these things. And I definitely like to bring this up as far as like, especially since there's a lot of mental health professionals and social workers and things like that in the room. We certainly hope that this will lead to referrals our way, and we also try to be a resource as far as a consult resource in the community around things like psychosis. So just as far as kind of thinking things through when something that somebody's experiencing as far as an appropriate sort of referral. And One of these things is it a first episode of psychosis, or is it clinical high risk? And usually, as far as figuring that out, we're looking at frequency and duration. Oftentimes, the first episode is going to look like psychotic symptoms that end up with a hospitalization. And then once they kind of stabilize, they're discharged home, then we'll probably get a referral or hear about it. So we're kind of thinking about at what levels are the symptoms persisting after that? Is it complete remission? Is it still at a level of full psychosis? Is it at a level lower on that psychosis spectrum? And the big thing that we're also looking at is insight in general, as far as what does the person make of these symptoms? Are they experiencing them as real? Do they think that aliens or demons really are doing something to them, or messing with them or something like that? Or is it that it just sort of like feels like that in the moment, but afterwards they know that it wasn't real and was just kind of a strange experience? Insight's a big thing as far as clinical high risk. And also in general, their change in functioning. How big of an impact has this had on their social life and societal role? And even if they are kind of performing at their previous level, is it taking a lot of extra effort? Another really tough one is trauma symptoms or clinical high risk, because trauma, as we said earlier, can really increase a person's risk of developing psychosis. The symptoms can look very similar. We often hear feels like things aren't real, and that can, with just that information, that could be trauma or clinical high risk. So the questions that we ask ourselves then is, as far as does this person need specialized trauma treatment, or does it make sense for working with us, is are their symptoms only following the theme of their trauma? Were they abused by a male person and they're just hearing that person's voice? Are they walking down the street and being afraid of just males, or are they scared of anyone out on the street? So with that question is like, is it in line with the theme of their trauma, or what happened to them? Or is it generalizing to they're suspicious of everyone? Some of the questions around trauma, but that definitely gets a little bit challenging as far as differentiating. Substance use is another big one. Psychedelic substances can cause hallucinations or cause paranoia and things like that. One thing we know is that marijuana use, especially heavy marijuana use as an adolescent, really greatly increases someone's risk of developing psychosis. Sometimes taking an edible or doing a dab or getting way too high can be the stressor that sort of tips people into a first episode. And sometimes we'll see where somebody will have psychotic symptoms when they're high on something, and then even once they've come down, some of those attenuated prodromal symptoms on that spectrum are persisting afterwards. So if someone's using a psychedelic every day and that's causing their hallucinations, they're probably not going to be appropriate for our program. That being said, this is also a tricky one, because not everyone who uses cannabis becomes psychotic. So if a person does, that probably means that they have a higher risk of developing psychosis, which is the folks that we're trying to look for and work with. But the thing that we're usually trying to look at is it persisting when, are these symptoms persisting when they're abstaining and that substance has cleared their system? Bipolar disorder can be another difficult one. Is it a first episode of psychosis, or is it a first episode of mania? When it comes to mania, you usually see things like grandiosity, impulsivity, rapid speech, not needing to sleep. When it's the first episode of psychosis, there's usually some paranoia involved. Usually, but not always, not really this grandiose thing. It can actually be sort of the opposite, where they feel really kind of down about themselves, and usually also has some delusional or bizarre thinking going on. And another question we're looking at is, are those symptoms only happening during a manic episode, or are they having some psychosis symptoms outside of those episodes? And there can be a lot of stigma and barriers to care as far as psychosis goes. Some, folks may think that these symptoms will pass and don't really want to seek help. They might not understand what's happening, and try to ignore it and not want to believe that it's happening. They can feel embarrassed about it, not know who to go to for help. And also, I mean, if it's severe enough, some people can be afraid that if they do seek help, that they're going to be told that they're going crazy and they're going to be hospitalized and taken away or something like that. So sometimes as providers or folks in the schools, it's you may notice these types of changes that we've been talking about before somebody actually starts to really sort of seek help. And so as far as treating psychosis, I think there is a myth out there that the only thing you can do for psychosis is to medicate someone. But there's a lot of research and evidence, and that's sort of why our program exists and other programs like ours exist, that there is a lot of evidence that there are ways to treat psychosis, and there are things that are effective and helpful. And as far as that goes, one of the big things that we look at and talk to folks about is the stress vulnerability model, that if somebody has a bucket that is filling up with stress, and the stress is the water that's filling up that bucket, and when that bucket fills up all the way up and it sort of like gets kicked over, and that might look like having a panic attack, or having a first episode of psychosis, or just a really significant, severe increase in symptoms. We talk about managing stress and just how much of an impact on symptoms stress has. And we liken predisposition to having a smaller bucket, or kind of like starting off with water already in your bucket. But the good news about that is that it's not an inevitable thing that bucket is eventually going to fill up and tip over. There's a lot of things that we can do to relieve some of that water and release some of that stress. So things that can act as sponges, or a different analogy, kind of drilling holes to release some of that water. And these are the things that in general we know are helpful to well-being and mental health and things like that, like social support, exercise, healthy eating, family support, avoiding substances. Can be things like coping skills developed in therapy, community resources. It can be medication, all these types of things.
Yeah, so just to continue with going through a list of interventions that are helpful in treating psychosis. Another one in particular is supporting key relationships. So that individual's family and friends through doing psychoeducation with the family to help the family understand how to best support the individual is really impactful. Also in therapy, retraining thinking patterns, so cognitive behavioral therapy. On our team and on many teams that treat this population, there are peer specialists. So that is a person who has also a mental health diagnosis with psychosis, and they have recovered, and now they are able to help people experiencing the symptoms for the first time. And it's really helpful for a lot of people to hear it from someone who's been through it, and seeing that they can recover. Involvement in school and work at a level that a person can be successful is really helpful intervention. And as the occupational therapist, that is one of my primary roles on the team, is looking at how to increase a person's skills or decrease the demands at work or at school to match the person's level of functioning. Overall wellness, like Jesse mentioned, as well as medication to decrease the dopamine pathway activity and to treat mood instability. So this slide just highlights some common reactions that families have to hearing or learning about a loved one's experience with psychosis. And those include a variety of things such as guilt, anxiety, grief of because of the stereotype that if you have psychosis, you can't recover. And so kind of grieving that loss, feeling sad and confused, worry, fear, isolation. So it's a really significant diagnosis, and for family members, it does change kind of a lot of perceptions. So working with families is really key in supporting people who have a first episode or are at high risk of developing psychosis. And this is just reiterating that reducing the family stress and to provide education to the family on why a person may be behaving the way that they are, and then what they can do to help. For example, some people with psychosis could be really overwhelmed by a lot of sensory information. So one thing that I can do is educate families on how to make the environment more calm for the person. So decrease noise when possible, decrease lighting when possible, so that the person doesn't become overwhelmed. That's just one example of an intervention that families can implement on a daily basis to really help a person with psychosis. And the CONNECT team is coordinated specialty care, and that is the kind of gold standard of the best way to treat this population. So it's multidisciplinary, and as well as like taking different approaches, including medication, psychotherapy for the individual, the group, or in groups, or for the family, as I mentioned, supported education and employment, as I mentioned, really helping a person be successful, and not just kind of giving up, saying like, this is too hard, I can't do it, but really finding the best fit for the person. And case management services and peer support. And coordinated specialty care teams have the philosophy that recovery is possible and resiliency is possible, and that shared decision making and treatment is really key into recovering.
Yeah, and so our team kind of offers all of these things, but we don't force anyone to do all of them or anything like that. It's always a discussion with who we're working with, what is most appropriate, and that can sort of range from maybe they just need some psychoeducation to understand what's going on for them, and they feel better and are able to take that and go forward, or to sort of ongoing treatment with medication and therapy and occupational therapy, as well as kind of talking with a peer specialist as far as what they're experiencing. So it can be a big range as far as like what we're able to offer someone. And so Connect is a grant-funded program. So at the moment, we're currently serving folks between the ages of 12 to 25 that are living in Bernalillo County. And to be in our program, the other qualifying factor is that they are determined to be at clinical high risk of psychosis using that SIPS. So kind of our referral process is usually someone is sent our way. We'll do that initial PQB screening over the phone. Then we'll do that more in-depth SIPS assessment to explore those symptoms. And if they, and at that point, they'll be determined to be eligible for the program or not with that assessment. And it's just something we like to let folks know, and just sort of what the process looks like as far as entering our program. So please contact us with any referrals that you might have. Our phone number that's our main phone number, 272-7809. It's that number is, you'll most likely leave a voicemail. That's just how it goes with that particular phone number. You can also email us. And also, like I said, we want to be a resource as far as questions about psychosis in the community. So even if you're somebody who is working with someone in a school that is not in Bernalillo County, if you have questions about psychosis or what things are looking like with someone a young person that you're working with, we're happy to be a resource for any sort of consultation or anything like that as well. So feel free to reach out, leave a voicemail, and I'll give you a call or contact us by email. Yeah, but those are the main things. I'll leave this slide up a little bit longer with our contact info, and then we can open it up for questions.